The standard first-line treatment for microsatellite stable metastatic colorectal cancer is modified FOLFOX6 chemotherapy plus the VEGF-targeted monoclonal antibody bevacizumab. And this study sought to test the hypothesis of when you've got colon cancer cells dying, what's probably a very immunogenic cell death during chemotherapy, does adding in a CEA-targeted vaccine to create some antigen-specific T cells, and then adding in the anti-PD-L1 antibody Avelumab, does that create a situation in which you may improve clinical outcomes, such as progression-free survival? So this study was a randomized phase 2 trial where patients were randomized in a 1-to-1 fashion to modified FOLFOX plus bevacizumab versus that standard of care plus Avelumab plus the Ad-CEA CEA-targeted vaccine. The study started out with a safety lead-in, 6 patients to test the safety of that combination. Unfortunately, the first patient developed neutropenic typhlitis and passed away with a bowel perforation. And after looking into what others had reported, combining pembrolizumab with FOLFOX in a previously reported abstract was shown to increase rates of higher grade neutropenia and neutropenic fever. At that point, we decided to omit the 5-FU bolus to lessen the chance of higher grade neutropenia. And subsequently, in the other 5 patients on the safety lead-in, the regimen was well tolerated. In the randomized portion, 10 patients were randomized to each arm. In terms of safety, we saw not really any safety signal out of what would be expected from those treatments alone. There were many asymptomatic lab abnormalities attributed mostly to chemo. In regards to immune toxicities, there was 1 patient with a grade 2 arthralgia. Otherwise, we did not see an unexpected frequency of immune toxicity from the immunotherapy. Additionally, what we did see was with the CEA-targeted vaccine, most patients experienced fever, chills, flu-like illness, and/or injection site reactions, which is expected with the vaccine and is transient. In terms of outcomes, the response rates were the same in each arm, 50% for the standard of care and the standard of care plus the immunotherapy. Additionally, a preliminary analysis showed overlapping progression-free survival curves, and a preliminary futility analysis predicted a very low likelihood of identifying a statistically significant difference in PFS, and the study closed to accrual in December of 2019. Since this was a negative study, it naturally won't have an impact on practice, but I think it does provide some insight. It suggests that addition of at least this type of immunotherapy to the standard of care chemotherapy in the first-line setting for microsatellite stable metastatic colorectal cancer does not enhance the response rate or improve progression-free survival.